What makes you think you can go that far?
Alyssa.
Hello.
Hello. All right, good. I'm on my phone because, weird computer issues still today. So thank you.
For everybody that's already signed on, if you do have questions during the presentation, you can use the question and answer feature down in the toolbar. Chat you can use if you have any like technical questions that you need help with, like connection stuff. But if you have actual questions for the presenters, use the question and answer feature so that we can track those questions.
Thanks, Alyssa. So everyone will remain muted until we get started. If you are on the chat and you can hear me, if you'll chat in. Yep. All right. So Alyssa and I are muting ourselves so you don't hear background noise while we're waiting. We've got about 3 more minutes. We'll try to get started right on time.
For those just signing on, if you have questions for the presenters about COVID, you can ask in the question and answer section. But if you have technical questions or you need help because you can't hear something or can't see something, you can use the chat function. The difference is that in the question and answer section, we can actually track these answers and get the answers back to you at a later time if we need to. Thank you.
We are going to give it just 1 more minute, so be patient for just 1 more minute. I just want to check, did Kim, were you able to join? Are you on? I might have to unmute you. Let me figure that out. Alyssa, do you want to start us off, or would you like me to go ahead and get started?
Sure. So I just have a couple of like little administrative things. So again, if you have questions about the content of the presentations, you can ask them in the question and answer section. This way we can track the questions asked and send out any information later. And if you just have technical questions or you need to know something about signing people into the webinar, you can use the chat function. I have had several questions of people wanting to add people to tonight's webinar. Please do not share the link for tonight's webinar because we do have a limited number of spaces in the room, and the people who registered for the course are the ones who are joining us tonight. This presentation will be recorded and they can listen to it at a later time, but we will not be adding any more registrations to tonight's event. You will get an email tomorrow morning with a link to your CE certificate. So just bear with us. I do have to check everybody in and verify that you are on the webinar. So tomorrow morning sometime you should receive an email with a link to your CE certificate. And that's all from me. And Tracy, do you want to introduce yourself or would you like me to do it?
No, I can do it. Okay. I will ask that, so Alyssa's going to be kind of monitoring the chat and the Q&A for us. She will be responding if she can. I am very challenged today, multitasking, so I'm not even going to try to attempt to manage what I'm looking at and trying to do the Q&A at the same time. So, but we are not going to open up the lines for questions and answers live. We will respond to the questions that we get and probably try to post on the CODHA website a little bit later this week, the responses that you all have. So I'm also going to ask that you all please be very kind. And this is a really hard time for all of us. Times are very uncertain. There's a lot of fear and anxiety about life in general, our employment situations, what's going on in the world. I am the executive director of the Colorado Association of Local Public Health Officials. I represent the health departments that serve every single county in this state. My members are on the front lines doing testing, following up with persons under investigation, case contacts, all of the things that are part of what is responding to COVID, my members are doing, and I'm one step behind them on that. It has been one of the hardest weeks in my entire career, and I think that's saying something. So while I'm not an expert on COVID, I have to know a lot about it, but I may not have your answer. And the fact of the matter is this issue is changing on an hourly basis almost. So nobody may have the answers that you need. But I do ask that you please be patient and be calm, and everybody's doing the best that they can in this situation. I am a dental hygienist, graduated from the University of Colorado in 1991, practiced for 13 years. Started with the state of Colorado, my public health career in 2002, became the state dental director in 2008, left to work in California in a county for 6 years, and came back to Colorado 2.5 years ago to take the position here at the Colorado Association of Local Public Health Officials. So I am one of you, and I know what it's like to be out there doing this on a daily basis. I'm going to ask Kim to go ahead and introduce herself because she's our infection control expert that will be able to tell you a little bit about some of the questions that you posed earlier related to infection control procedures.
Tracy was one of my hygiene students at the University of Colorado, so it's fun to have you in the role that you are and see you evolve where you are. But yeah, I'm a dental hygienist as well and taught at University of Colorado School of Dentistry for 32 years and served on the state board for 8 years and have had my own business in teaching and helping offices be in compliance with OSHA infection control for 30 years. So I'm happy to be here tonight, and I know we've got a lot of questions on infection control. So I'll just wait until I hear those questions or whoever's leading the meeting, and then I'll be happy to answer.
And I want to thank Kim for volunteering when I frantically emailed her asking her to participate on this call because I knew there would be a lot of questions about PPE and infection control, and I am definitely not the expert on that. So let me tell you a little bit about how we're going to work tonight's video conference. I'm going to talk a little bit about what COVID is, how it spreads, what we need to be worried about, talk a little bit about what public health is doing, and if you need love, this is my dog Ripley. He joined me in my office tonight, so he wasn't stuck in the crate all night long. So you might hear me telling him to get down or get out of the cracker box in the corner over there. I also want to go over and make sure that we understand what dental offices should be doing about COVID during this time, infection control, procedures, et cetera. How it's really, really important in this period of stress and anxiety that we all take care of ourselves, because we can't take care of others, including our immediate family, if we're not taking care of ourselves. And then finally, leave you with some official resources and information that might be valuable for you to stay connected to as this progresses. You have probably all received by now the email from the Department of Regulatory Agencies stating that right now there is no intention to direct providers to close their offices. And I think that the Department of Regulatory Agencies does a balancing act between providing guidance and information that people need to make decisions and leaving the decisions up to the providers. I rather doubt that the State Health Department or even the Department of Regulatory Agencies will come out and say you have to close, but they're providing you with a number of resources and information that you can use to make that determination yourself. Has everybody received that information in their emails? You can chat in. Yep, all right, I'm getting lots of yeses. Perfect. So what is COVID-19? Well, COVID-19 is actually the disease that's caused by the novel coronavirus. You all can get this information from the CDC website. The novel coronavirus is part of a family of coronaviruses that are common in people and many different species of animals, including bats and cats and other animals like that. Other coronaviruses that you may be familiar with are MERS and SARS, and it's called SARS-CoV-2 because it is the second version of this kind of SARS virus that we've seen. One of the things that we understand about the folks that originally contracted this disease is it was from a seafood market in Wuhan, China, and they do believe it came from a bat, but they are not absolutely sure. Last week, you will have seen that the World Health Organization actually declared COVID-19 a pandemic, meaning it is perverse across the world. So a number of countries, I think we're up to 130 some countries that have cases of COVID-19. This is probably the first time we have seen anything like this. Even previous outbreaks of illness, including Ebola, MERS, H1N1, were not as serious as this. And why is COVID-19 more serious than the common flu, even though it is in the family of viruses? That is part of the common flu because of the fatality rate. Folks have been asking me why it is that we have not seen more research about COVID-19, and that's because there isn't a lot of research that they can get published yet. So the information that we have right now is not from peer-reviewed journals. It's actually from articles that have been submitted for publication. But the majority of people are still dealing with fighting this initial outbreak of the disease, and so they haven't been able to publish a lot of research reports yet on COVID-19. I want to talk a little bit about how the virus spreads. There is person-to-person spread, and you will often hear the words community contagion, community spread, or community transmission, meaning that there is no travel history or other kinds of history of where the virus could have been picked up by those individuals. It's being passed from person to person. People who are in close contact with each other within 6 feet and through respiratory droplets produced when an infected person coughs or sneezes. These droplets can land on the noses, mouths, and nearby areas and possibly inhaled into the lungs of the individuals. So COVID right now is presumed to be passed person to person through sneezing and coughing, and the virus is then inhaled through those aerosols into a person standing in close proximity within 6 feet. That's why social distancing is such an important factor in reducing the spread of this infection. People are often asking if someone can spread the virus without being sick. People are thought to be the most contagious when they are symptomatic. Symptoms range from very mild to very severe, and you may have seen today that we've had our second fatality as a result of COVID-19 in the state of Colorado. I don't have the information on where that fatality occurred at this point in time. Therefore, it might be possible before people show symptoms or have very mild symptoms to be passing the infection from person to person. There is thought to be some spread from contaminated surfaces of objects because they really don't know how long how long the virus lives on surfaces, because they haven't had the time to do the research on that. What they do know is that in experimental settings, the virus has lived up to 24 hours on stainless steel and other hard surfaces, up to 3 hours on porous surfaces. But those were controlled environmental experiments, and so those cannot be guaranteed to be predictable for the general population out in the real world. It is known that this virus spreads very easily between people. And so we very, very much have to be careful around others, particularly those most susceptible to the infection and those at risk for the most severe symptoms and consequences of the disease. Older adults, the cases are primarily worst in individuals 60 and above and those with underlying health conditions such as cardiovascular disease and respiratory illnesses. I'm going to stop there and see, Alyssa, if there's any questions about COVID-19 itself, how it's passed, or anything like that right now.
Sorry, I'm trying to help people with login issues. I have not been doing a great job of monitoring, but somebody says if they become infected tomorrow, are they immune now? Is it similar to chickenpox, or once you're exposed, you are immune?
So there is some immunity. If you have it, you cannot catch it again this year. We do not anticipate that there will be permanent immunity. It is a family of viruses that mutates frequently with variations, just like we get the flu and colds every year. And they do know that there is temporary immunity. They don't know how long that lasts. It's too new to know how long that lasts. So if you get COVID-19 this year, you are likely immune for this outbreak of COVID-19.
Then another question was, it says mainly passed airborne, but does that mean possible but less likely passed by surface contamination?
There is a study, and I will make available the resources that I used in reference for tonight's presentation for Alyssa to either put on the website, or you can use the Google Drive that I set up. There is the risk of aerosolization of the COVID virus, so CoV-2, through aerosols living on surfaces. And that is part of the reason why it's suggested that folks don't touch their faces and that you wash your hands. If you do pick it up from a surface and then touch your face, your eyes, your mouth, your nose, then it will be absorbed through your mucous membranes and you will be exposed to the virus. I've said around my office, don't pick your nose or suck your thumb, and don't change your contacts unless you wash your hands. So there is the potential that it will live on hard surfaces and it could be picked up and pass through your mucous membranes. It does not get absorbed through the skin or through open wounds. They have found the virus shed in stools and in blood, but not in urine. And Kim and I had a conversation about saliva on Sunday, and nothing that I saw said absolutely that it was present in saliva, but it is present in fluids from the lungs and nose, so you could assume that it might be passed through saliva. So what do we need to know about COVID-19 as healthcare professionals, with the potential that there is contamination from surfaces to patients? I think we need to follow the recommendations that are being made for anyone with an exposure. If you yourself or a patient thinks that they have been exposed to COVID-19 infection, they need to remain at home, even if they are asymptomatic, for 7 to 14 days. Because the chance of transferring that to somebody else, even if you have very minimal symptoms, is high. If you are symptomatic, the symptoms are fever over 101 degrees for a sustained period of time, dry coughing, and difficulty breathing. Up to 2 days before onset of those symptoms, some cases in China reported diarrhea and vomiting, but they're not absolutely sure that it was associated with the COVID virus. So anyone that's symptomatic should probably be asked to reschedule their appointment if you are not adopting the recommendation that all elective dental care be postponed. We obviously understand that standard precautions are intended to keep cross-contamination to a minimum, and I'm actually going to ask Kim to answer. There's a lot of questions coming in about what kinds of disinfection procedures are appropriate, PPE, those kinds of things. I'm going to turn it over to Kim to talk a little bit about that, but I am going to answer one question that I just happened to see come up in the chat. We are asking you to use the Q&A if you have questions. COVID is not transmissible through open wounds, only through mucous membranes. Kim, I'll turn it over to you for a second.
All right. And I agree. If you guys, on the bottom of your toolbar, there's a chat and then there's a Q&A. And I think a lot of people are posting questions in the chat, and that's more for Alyssa to monitor if you're having problems. But let's start because regardless of where you put your question, I've had a chance to kind of go through all of those. So let's start because there's a ton of questions on disinfectants and what's effective and that sort of thing. And then the second biggest question, and thanks to the many of you who sent Alyssa questions prior to tonight's meeting. She sent those to both Tracy and myself. So I had that opportunity to go through that long list and kind of, I see where the priority is. So the first thing is the disinfection. And I think, like Tracy said, and I'm not a microbiologist, but I've had access to information, and just what I think everybody needs to know. You know, we go back to Spalding as far as his classification of inanimate surfaces. I don't know Dr. Spalding. From many years ago, I remember even my own training, but what a genius he was. He actually classified the different viruses as well. And so the COVID-19 is classified as an enveloped virus, which is one of the easier viruses to kill. That's just the bottom line. So generally speaking, I took this off of the EPA's website today, And I want you all to use the EPA for your resources, because even all the questions I'm getting in my personal email and, God forbid, social media, there's so much inaccurate information. And even, I don't know, in our chat tonight, some people were maybe responding to different questions, but if you were answering questions, I was thinking, no, that's not correct. So let's be careful about what we share. So the enveloped viruses, it says here, are the least resistant. And what happens is, even though they're enveloped, if I think of a barrier around the outside, they're very susceptible to just about any liquid or product that they come in contact with. So the next thing the EPA has done is taken the list of current disinfectants that we have right now that have EPA approval. And if you've ever heard me or anybody in infection control talk, we usually talk about something that is tuberculocidal, something that has a TB kill time. And while tuberculosis is a bacterium, it's one of those microorganisms that's very hard to kill. So I'm not going to say that anything that has a TB kill can also kill this, because they're very different testing procedures. What the manufacturers of these products do is, prior to this outbreak, there have been, obviously, I think Tracy said this, other coronaviruses. And so, unfortunately, none of the products on the market today have approval for what we're dealing with as far as the SARS-CoV-2, which is what we're calling the COVID-19. So what the EPA has done is it's considered similar to the previous coronavirus and coronavirus claims, and they're classifying them under the letter N as in Nancy, and that's an emerging pathogen. So when something is emerging and we don't have any history on it, they look for something that is similar, and then there are assumptions made. So what the EPA has done, and they updated it, I believe, either just yesterday or the day before, it's the list N. N is in Nancy, and maybe we can get it, Tracy, up on the Google Docs or something like that. But it was easy to find. I mean, if you just search for surface disinfectants, coronavirus, EPA, you'll have no trouble finding it. And then the questions that you all want to know. So somebody said, are CAVI wipes? I will tell you that yes, Cavicide 1, Optum 1, even Optum 33 TB, which is an older product, it has the claim for the previous coronavirus, and those manufacturers have received approval for the COVID-19. So the major disinfectants that we use in dentistry are definitely going to be effective against the product. My concern was the first question I saw up here. It says, are Cavicide wipes sufficient? And then anybody who's ever heard me lecture, you know, wipes basically sanitize or clean. They generally don't disinfect. Remember, it's all about following the manufacturer's recommendations to keep the surface wet. So regardless of what you're doing, I'm going to go back to my standard message that we've had since 2003, 2008, 2011, 2013, 2016, that the CDC says if the surface is difficult to clean, it has to have a barrier. So it's less about maybe the surface disinfectant guys, and it's more about the barriers. So when you're using barriers, you throw away, you discard the barriers after the patient leaves, and the bugs are in the trash can. And then typically what we need to do is sanitize or clean. Those two words are synonymous, sanitize and clean. You just simply wipe things down, which in fact would then a CAVI wipe or any of the wipes on the market, and you can place your barriers after that. If somebody is still not using barriers, which would be disappointing, but if you touch a surface and it has to be disinfected because there wasn't a barrier, you would absolutely have to follow the product label, which is to clean the surface or sanitize it first, and then you apply the disinfectant for whatever the TB kill time is. And again, that's how they base it, with tuberculosis being one of the marker organisms that's tougher to kill. For instance, with CAV1, it's a 1 minute TB kill time. Cavicide is a 3 minute. Optum 1 is a 1 minute. So you just have to follow those instructions. So I think, unless Alyssa, you tell me, I think I've said everything I want to say about surface disinfectants, and hopefully everybody got the message that it's more about the barriers than it is about the disinfectant.
Yeah, I mean, there's still a lot of questions about Cavi wipes versus Cavicide versus Cavicide 1. I think the biggest thing is to look at the list that Kim referenced from the EPA, which we will send out with the question and answers. And to make sure when you look at that list, you look it up by the EPA registration number and not by the name of the product, because several products have different names in different countries. And so it's good to know, look up on your bottle
Correct.
what the EPA registration number is and look on that list based on that, because that list is getting updated continually as they are doing tests and research on these products.
And you can type in, that's an excellent suggestion, because a lot of our products that come, they're, for instance, Metrix makes Cavicide, but Metrix sells that product to Shine and to Patterson, and each of those companies call it something different. And so Maxi Spray Plus, so you won't possibly find the name of your disinfectant. But if you type in the EPA number, and if you didn't know this, it's a good hint, there's going to be usually a longer number, a shorter number, and a shorter number with dashes. And I think if you can't pull up what you want, knock off the last 4 digits, because the last 4 digits sometimes are the private label. So you may not even know that you're actually using Cavicide. If you're using Maxi Spray Plus, I think it's from Shine, that is Cavicide. But like Alyssa said, don't start going through the list. I mean, it's many pages long. The fastest way to find what you're looking for is to type in the EPA number. And again, type in the whole number, the complete number. And if the name of the product comes up something different than what you're looking for, kind of start shortening it off the back end. But boy, I agree that the EPA list is not easy, because there's so many companies out there that buy it from somebody else and then they tack their name onto it. But I just wanted to reassure you, mostly the brand names we talked about tonight, I can assure you that Cavicide, Cavi1, and then the wipes that go with those are for sanitizing. It's usually a liquid product, more of a spray, because the wipes just don't stay wet. So if you're going to try to disinfect the surface, you'll need probably this, the liquid, not the wipe. But anyway, good suggestion, Alyssa, to type in that EPA number.
Kim, there's some questions on here, and I know you cover these in your normal infection control courses, but if we use barriers, do we still need to spray wipe? And our office uses 4x4 soaked in Cavicide. Is that effective? And
yeah. Well, so we'll just stop right there. Soaking anything 4x4s is unacceptable, because that's off-label use, and we don't know if it's the cellulose or the bleach or whatever's in the gauze, but it deactivates the disinfectant. So we should never pre-soak anything. If you want to use 4x4s or paper towels, things like that, you can use them immediately, but you cannot pre-soak. So now the next question somebody had about barriers. I think the biggest message I have tonight is that we aren't really going to do anything different than what we did a month ago, 6 months ago, a year ago. I mean, the recommendations since 2003 are still in effect. So we're still practicing standard precautions. What we have done since 2003 is going to protect us still today. Now, we're going to get to the aerosol discussion and that sort of thing, but we're talking about surface disinfectants right now. And you do not need to do anything different. So if you're using barriers, like most of us are, you place on the barriers, and after the patient leaves, you remove the barriers. The CDC actually says you don't even have to sanitize, but I think if you've heard me lecture before, we all feel more comfortable at least wiping things down just in case something leaked. And then with clean, ungloved hands, you place new barriers. So nothing has changed. There's no need to double wipe. There's no need to use double barriers. I mean, everything we did before should protect us. So Alyssa, did that pretty much finish the disinfectant type questions, the surface disinfectant?
Well, no, there's a lot of them. Everyone's going to ask every single brand and every single protocol, but I think I would just advise people to take a thorough infection control course. And these are things that apply all the time, not just right now. And we'll try to send some information out with a question and answer. There have been a few questions, and I know we got these questions ahead of time too, but about ultrasonic use, aerosols, and what type of masks we should be using, and if a face shield is necessary.
Well, I quickly pulled up some of these, and it says, it's been brought up that Cava wipes do not have an effect on COVID-19. Is this true? The answer to that is no. I obviously said Cavicide, Metrix makes Cavicide, and Cavi1, it's effective. Somebody mentioned PD Care, that the Cavicide was sold out. PD Care is manufactured by Patterson, I believe. And that is the same product. If you look at the EPA number, and again, I don't have my comparison list, but I'm pretty sure. But if PD Care, again, you go to the website, type in the EPA number, and you will find. Regular Cavicide is the 3-minute kill time, and Cavi1 has the 1-minute kill time. So I've quickly, like she said, I think I'm going to move on to the next topic. Sound good? Alyssa?
Yes, I think that sounds good.
Okay. I think the next biggest question asked on the Excel that you sent us, and then I've quickly glanced over these, was the aerosols. So aerosols, as far as what would protect us against the aerosols. So we'll start with masks. There is a question about the N95 respirator masks. Should we be using those? And the answer is absolutely not. We need to save the N95s for the healthcare, the nurses, medicine. There's already kind of a shortage. They do need to be custom fit. It's a very different mask. So basically, I'll go back to what Tracy said. It is aerosolized, and so we do the same thing we've always done, is we wear a mask. Level 1 masks generally are for non-aerosol procedures. Level 2 masks are for routine procedures that don't involve heavy aerosols. And then a level 3 mask would be for the things that, cavitrons, ultrasonics, high-speed handpieces, anything that has a continuous aerosol would be the level 3. I understand masks right now, some people are concerned about what would be a shortage. And my information, even as of today, is that most suppliers, if you ask, you have to call, but they are meeting the needs of everybody's based on your past ordering history. And now that offices, because of the 3-week, kind of take it easy for 3 weeks, if you're following that recommendation, it's going to help replenish our PPE supply. So yes, you wear the mask that's appropriate for the procedure. If for some reason you don't have a level 3 mask, I would recommend wearing a face shield in front of the mask, and that will help. I checked with OSAP today, and that's one of the recommendations. We never rewear a mask ever more than one patient. No exceptions. If you don't have masks, you don't practice. A face shield alone is not sufficient. You have to wear a mask. But if you don't have the mask, a level 3, and you're doing an aerosol procedure, you would wear a face shield. And just so you know, in California, it is required that all hygienists not only wear the mask, but they also have to wear a face shield when they're using an ultrasonic scaler. So California took it, and this was years ago. This is nothing new. And the same thing with high-speed evacuation. That's huge. We have to use high-speed evacuation when you're doing any procedure that has the high aerosol. So what I'm saying is no saliva ejectors. I mean, saliva ejectors aren't going to cut it. So that's where we have all these, for the last several years, manufacturers have been putting engineering controls out there. All of there's so many brand names, I can't even mention them, but it's basically a tool for hygienists so that we can do hands-free, high-speed evacuation. If you don't have those in your office right now, you could have an assistant come in. If you can't hold the high-speed evacuation in one hand and your Cavitron in the other, ergonomically, that's not always easy. You could have a chairside assistant help you. So you have to wear the proper mask, and a face shield is always a good idea, and high-speed evacuation, and that will help you control the aerosols. So that answered the mask question. Anything else,
Yeah, there's
Alyssa,
still
on the
some
mask?
questions about level 3 mask versus N95 for this specific virus aerosol particles. And then,
yeah,
go ahead.
the masks aren't going to protect us. Level 1, 2, and 3 are not going to protect us against direct somebody coughing or sneezing in our face. That's not the level, but that's not their purpose either. The N95 respirators would, but those are reserved for people who are treating known COVID patients. So if, like Tracy mentioned earlier, if you're screening patients, as you should be if you're continuing to practice in the next couple of weeks, and beyond, while we're still in this situation, you should be doing the screening. And so the screening in some cases is again, asking them about their symptoms and temperature and that sort of thing. So we wouldn't be treating anybody in these next few weeks that has any symptoms at all. So you wear the mask that we have, either level 1, 2, or 3, based on your procedure that you're doing. N95 respirators are reserved right now and whatnot for, now if you work for an emergency situation where you're in a hospital and you're treating and patients, yeah, they're going to have N95 respirators, but they require a fit test to be ideal. So that's just something we typically don't do.
So a lot of other questions are coming in about masks. So what is the proper way to wear a mask? How long can you wear one mask? What makes COVID different that a level 3 mask isn't sufficient?
Well, a level 3 mask isn't even sufficient for TB. I mean, there's a lot of viruses and bacteria that even though it has a bacterial filtration ratio or whatever that's small, it could be that it gets through there. As long as you're breathing air is getting through, right? So it's possible for some of these very, very small particles. So it's not a matter of the mask being defective. Now, we do want to wear our mask correctly. And I've always said it should either be on your face or in the trash. It's a good fit. You pinch it around the nose. If you have the masks that pinch under the chin, you try to eliminate as many, openings as possible. But please, we've never been in favor of pulling it down under your chin. You wear one mask per patient, typically, and the CDC and research shows when the mask becomes wet, it loses a great deal of its efficiency. So typically a procedure of 40 to 45 minutes and we're breathing that entire time in a procedure. That's why they said one per patient, because it's kind of a rule of thumb, like 1 per hour. But we don't want to be going from patient to patient with a mask and transferring,
So I'm I'm going to jump in real quick, Kim, to address two questions specifically that came up. So one says that they feel like we're saying it's okay to use ultrasonics if you have a level 3 and a face shield with HVE. And then a second one is saying, what about asymptomatic spread that is happening? So there are two things going on here. We know what we know today, and there are things that we don't know today that we'll know tomorrow. And all of this could change tomorrow if they have more research and more information. So you have to assess, based on the best information that we can provide to you today, what your risk is and what risk you're willing to take. So we are not saying that it's okay for you to use an ultrasonic level 3 with a face shield HVE if you don't feel safe with that. We do know
I'm saying you should do that. You should have done that last year, and you should have done that 6 months ago.
Correct.
So I'm just saying, for now, that's the protocol.
That's what
but you're
we've got.
right.
And the second thing is, we know asymptomatic spread is happening. We do know there are patients out there that are not symptomatic, that are carriers of the virus, whether they be children, because they usually don't get a significant symptomatic form of the illness, or whether people are feeling better but haven't gotten over the mild symptoms that they might be feeling. That information needs to be taken into consideration by you and your practice owner, or if you are an independent practitioner, whether you choose to stay open or not, understanding that during this time, any type of public interaction in which you're in close contact, closer than 6 feet with individuals, is a potentially increased risk for exposure to COVID-19.
Correct.
So
and that's
we
why
can't tell you, we can't tell you what to do. You have to decide that for yourself based on what you perceive your risk to be. We can only give you the information that we have that's available scientifically.
And I think what a lot of people are facing, thank you. What we're facing is, the American Dental Association came out with try to limit all dental procedures to emergency only. So anything that's elective, which would be our hygiene procedures, should be postponed for 3 weeks. The Colorado Dental Association came out with the same policy. I noticed South Carolina today came out with 14 days. So and like Tracy said, this is only a recommendation. So that's where many of your Excel questions I read earlier and some I'm scanning here is, if your office is choosing to not follow that recommendation, because it is, I call it best practices. I think it's something that we should try to follow. And I just want to put a plug in here. Even though they're saying to not treat elective procedures, some people are thinking that means stay home. And I was thinking, looking at the list of people who are on the call tonight, and many of them I know, this is a great opportunity to do your spring cleaning. Even if you're not, catch up on your paperwork and do all that kind of stuff. So it's not like we're not working, but maybe we're not seeing patients, elective procedures. But if your employer is asking you to do that, that's an ethical situation that you, like what Tracy and I are saying, you have to deal with that. Is that a fair statement, Tracy? Yep, I see her shaking her head. So
yep, yes, it is. I'm typing, trying to be quiet, and muted myself. Sorry.
That's okay. That's okay. So I'm going to move on. We talked about the masks. We talked about the surface disinfectants. I did want to talk about the pre-procedural mouth rinse because, again, that has been recommended since 2003. Most of our dental and dental hygiene schools have been doing that since 2003. And if you want to read an outstanding article, the American JADA, Journal of the American Dental Association, published in December of this year, these authors went back and looked. What a timely publication, because they had to do this probably a year ago before we ever even knew. But they looked at all the studies that have ever been done on pre-procedural mouth rinses. And what I want to back up and say is the Centers for Disease Control in their 2003 guidelines recommended the mouth rinse prior to any procedure that involves aerosols, but there's really no science. It's one of those recommendations that some people didn't take seriously, because it does start out by saying there's no science to show that it prevents disease transmission. But what that really is saying is we can't do human studies. We can't put people in a risky situation and have some rinse with a mouthwash and others not, and put dentists and hygienists and see how many get sick. So it's one of those more anecdotal, but the research solidly shows. So again, JADA, December of 2019, the authors looked at all the studies ever done, and it does show that using a pre-procedural mouth rinse reduces the amount of antimicrobial bacteria. Now, I have worked a few hours today trying to figure out where did the American Dental Association come up with a 2% hydrogen peroxide recommendation, because I don't even know where that came from. I'm perplexed. I contacted OSAP and there's no answer. What I would recommend is using the CDC guidelines, and they recommend using either a chlorhexidine product or a CPC or an essential oil. So I'll just really reduce that back. The chlorhexidine products that we commonly know are Paradex, Paragard, Oris from Dentsply, Parex from Sunstar. The CPC, which stands for cetyl paradiddlyum chloride, long CPC is so much easier. That's like a Pro Health rinse. I know, Pro Health rinse from Crest, Total Advanced from Pro Shield Colgate, and then of course the essential oil is Listerine. So those have been approved, and those are the ones that all the studies have been done on. And usually, just guys, it's usually it's a minute rinse, which is ridiculous to have somebody rinse for a minute. So most of the studies, they ask patients to rinse for two 30-second intervals. Just a swish and spit, it's probably going to help. In one study, it showed that even just having patients rinse with routine water was more effective than nothing, and it was quite impressive. But and then in other studies, it showed having patients rinse with one of the mouthwashes we just mentioned versus chlorhexidine were very similar. So I wouldn't get hung up on what kind of, as long as it is either the chlorhexidine glutenate apparently has more of a lasting effect than perhaps either the CPC or the essential oil, like the Listerine. But that's a great idea, and it's been recommended since 2003, so yay, we finally get to do it again. So 2%, somebody has said, how do we make our own 2% hydrogen peroxide? And I don't have an answer for that, and I don't know where the hydrogen peroxide came from. I would follow the CDC guidelines, which have used for years, again, either using a chlorhexidine product, a CPC, or the essential oil, which is the only essential oil mouthwash I know of is Listerine. Any questions about pre-procedural? Go ahead.
No, I was just going to answer a couple other questions. So are there any other questions about pre-procedural mouth rinsing?
I think that the ADA was the one who released the recommendation of the hydrogen mouth rinse.
You were cutting in and out. Did you ask if the ADA was the one? It was the one that released the information.
Yeah, I was saying that I think ADA is the one that released that recommendation.
They are. They are. And it was one bullet point like halfway down, and it's where it started, and boy, has it gone viral. And I couldn't get through to the ADA because they're swamped, of course. And maybe there is some good knowledge they have about a 2% hydrogen peroxide that I don't know about. But what I do know is there's solid research for the chlorhexidine, the CPC, and the essential oil Listerine.
So someone asks if there's a potential, if a patient has a potential or exposure, or someone in their building or school was positive for COVID-19, should they be RS or if they traveled to a local Colorado hotspot. So the current recommendation is if you've had close contact for a prolonged period of time, occurring regularly, so 6 hours on multiple occasions, or you've traveled to one of the areas where community spread is hot, which is Gunnison, Pitkin, Eagle, or Summit counties, the state is asking that you self-quarantine for 14 days. If you feel like you have been exposed to COVID-19, you should probably self-quarantine for 14 days to reduce the potential of community spread. You will usually be symptomatic within 5 days if you've truly been infected. The next question, can you define exactly what ADA deems as an emergency procedure? I'm not going to say ADA deems this as emergency procedures, but what I have seen as the guidance is pain, swelling, or active infection. Does anybody else have another thought on that?
I don't.
I don't either. I think that's pretty typical of an emergency.
Yep. Yep. I think it's pain, and when I was on the board, pain and obviously comfort, get them palliative care, that sort of thing.
Right.
So if something can wait, it's not an emergency. I guess that's another. And I just saw a few questions here about on the pre-procedural mouth rinse, somebody thinking that maybe hydrogen peroxide was recommended because COVID-19 is susceptible to oxygen. I can let Tracy answer that. I couldn't find anything that even mentioned that in my research today. And number two, some of the products that were used in the early studies that were oxygenating products, they were not as effective as the ones that we just mentioned earlier. So do you know, Tracy, was there anything to show that COVID-19 is more susceptible to oxygen?
Not from anything from the CDC that I've seen.
Yeah, me either. So again, that's probably, just like why toilet paper is missing. Everybody comes up with reasons why. And the same thing, I don't know. Maybe hydrogen peroxide does work. But what I can tell you again is the other products have been researched and recommended for several years.
Somebody asked, why is there a list that has dentures and partials as essential dental care? Because we do know that particularly in older adults who are missing dentition, that their nutrition suffers and it can lead to a number of complications for their overall health. So particularly in elders that are needing dentures repaired or their dentures delivered or partials delivered, it is sorry, my dog's playing with his toy. It's critical to make sure that they have the dentition that they need to maintain proper nutrition, because that also helps them maintain their health. All right, we've got 5 minutes left. Do you want to do any of the other infection control questions, Kim, or?
The only other one here was hand hygiene, and there were quite a few on the Excel, because I think what we've hit tonight, and I wanted to reiterate, was really nothing has changed. We continue the same procedures we've been doing. And hand hygiene, somebody said, does the hand sanitizer have to stay wet on your hands for 20 seconds to be effective? And the answer is yes. It's actually 15 seconds. I think 15 to 20 seconds is what the CDC, what we know is from the time you start the water and stop the water, or the time you put the hand sanitizer on, 15 to 20 seconds is the rule. And so, yes, if you put on hand sanitizer and your hands are dry before the 20 seconds, you should have used more product. And the same with your soap. If your hands have to be under the running water for 15 to 20 seconds. It's not the whole time that you're drying your hands. And I did see a recommendation today, and I haven't been wearing rings for the last couple of weeks. I have been in some dental settings, and try to limit, when you're doing your hand hygiene, wearing rings. rings, and some recommendation even watches. You know, if you're washing your hands and your wrists and you want it to be effective and there's something there harboring the bacteria, it's not going to be effective. So a hint, don't wear rings when you're trying to maintain good hand hygiene.
Somebody asked if regular laundry is sufficient to hot water and laundry detergent for scrub, for cleaning your scrubs. Yes, it is.
Yes, yes.
As Kim said, it's an envelope virus. It's very susceptible to the things that easily kill viruses and bacteria. Just to clarify, are face shields mandatory for use with cabotrons and high speeds or just strongly suggested? In California, they're required, the recommendation is strongly suggested everywhere else. Is that true, Kim?
Well, yep, and you know me, I don't like the word strongly. The CDC recommends, and then it's up to the state board and OSHA to enforce it. So anything that's recommended by the CDC in my world is required. So it is required to use the high-speed evacuation and limit the aerosols during those types of procedures. But the face mask, no, there's no mention in the CDC guidelines at all, except to say if it's what, a best practice. So no, but California, like Tracy said, and I know they took it up a notch. So if you want to do that, and I do know many of us here on the calls, we work in the southern states, they actually wear bonnets, almost like a surgeon's cap when they're using, and it is taught in all of the schools, but nothing in the Midwest to the West, it's not taught. So that's an interesting thing that, you know, regionally, that they continue and we don't.
So a couple of final questions, and then one last thing I want to say about unemployment, because I know that's been a hot topic. I think you all can see this Colorado Dental Association's suggested questions for screening patients. First of all, if anybody's sick, they shouldn't be coming into your practice. I will say I state that unequivocally, and I think that if you're sick, you need to stay home, or if somebody in your office is sick, they need to stay home, because you don't know what it is, and not everybody is ever going to be tested for COVID. There just isn't enough resources out there. Somebody asked about hair, and should you be covering your hair? I don't think that that's necessary, but I personally always showered after I practice, so I would suggest you do the same thing no matter what. So you should wash your hair every evening after you get home. And if you haven't been doing that, you need to change your sheets and wash those too. And then... And that
question may have come from, Tracy, that question may have come, I saw that, and that's why I mentioned it. If somebody was educated in the East or the Southeast, they taught that in school. But you ask, and then none of them do it in private practice. It is not mentioned anywhere in the CDC guidelines to wear that kind of protective attire, a bonnet. But and I just want to thank Haley. She mentioned the ADA says it's 1% hydrogen peroxide, not 2. My apologies, but I just wanted to say thank you. So, but I'm with Tracy.
Teresa,
no hair. I mean,
yeah. Go ahead. So
Nope.
Teresa, I want to say we're not asking you to diagnose COVID-19, but we are saying that if you have concerns about patients and whether they should stay home, there are some guidelines about why you should stay home, just like we say there are guidelines why we should stay home. If you're running a fever, if you have a dry cough, if you have trouble breathing, if you have symptoms of, if you have typical flu-like symptoms, you should not be out in public, period, right now. So last thing, and then we're going to call it a night. The state of Colorado has loosened up their unemployment and insurance regulations. So if you are in an office that has closed and you do not have paid sick or vacation leave during the time that your office has closed, the state of Colorado is allowing individuals that have no other options to file for unemployment insurance benefits. That doesn't mean 100% of your salary, But that does mean there are some options for individuals that are affected by COVID, but not under the rules and regulations around screening or infection. You can claim unemployment if your office has closed and you do not have paid time off of any kind. And then the last thing that I will say is please keep up to date on the reliable sources, the Centers for Disease Control, the Colorado Department of Public Health and Environment, and even WHO if you want to, although those are more global, so you will probably find better and more accurate information on local websites here in the United States and in Colorado. I don't have a crystal ball. I don't know how long this is going to last. I will tell you it will get worse before it gets better because we are testing more people and we are trying to understand what the spread is. There will be more fatalities. And so please just take care of yourselves. Go have conversations with the offices that you work in about the information that you learned tonight. Ultimately, the decision is yours and the providers that you work with as to your own perceived risk and whether you should be practicing. Kim, any closing comments?
No, you did a great job, and I know we all appreciate what you're doing there. I mean, I know you're bombarded, and we're all trying to just keep our heads above water and stay positive.
Exactly. Alyssa, any closing comments?
Yeah, so there a lot of questions just started popping up about the unemployment, and then there were some questions about pulling your mask under your chin. I just want to let everyone know that Tracy, Kim, and I will look through these questions and answers, and we'll try to send out the answers or a summary of the answers because a lot of the questions are repeated. And then also tomorrow morning, you should receive an email with a link to your CE certificate. And so if you don't receive that, feel free to reach out to me. Most of you know how to get a hold of me, but it's just info, I-N-F-O, @CODHA.org. If you do not receive the email, but give me a little bit of time in the morning to get that out to you, because I do have to check everyone in from this evening's course in order for that to get sent out.
Thank you, everybody.
Thanks, guys.
Thanks, Kim. Thanks, Alyssa.
You bet. Bye-bye.